Okay, so basically we are basically going to do post operative consequences of bowel surgery. Okay. Basically, when we are talking about that, okay, as we all know, okay, the complications are basically when we're talking about bowel, we are basically talking about the contents of the intestine, large intestine and small intestine. Okay, so basically the main complications of this are basically first and foremost is surgical site infection. Surgical site infection. Okay, with that we are basically writing it down as SSI. Okay, now because it is an open procedure, okay, if it is performed openly rather than laparoscopically, okay, so it can be basically it can lead to surgery, can lead to contamination. It can lead to contamination of the peritoneal cavity, contamination of peritoneal cavity, and the wound itself, okay, or basically the surface of the surgical wound, surface of surgical wound, okay. And this can be basically we basically, to prevent this, we can basically do is we give them antibiotic prophylaxis. We give them antibiotic prophylaxis. Okay, so it is that one is the main one. Okay, next is the initial one. We can say it is an initial one. The next one is anastomotic leakage. Anastomotic leakage. Okay. Basically, when we're talking about anastomotic leakage, okay, now this is a serious complication, a very serious complication, a very serious one. Okay, and it can basically lead to it's an emergency situation and all. Okay, now in this basically we have to first and foremost is we have to diagnose we have to diagnose the anastomotic leak. Okay, now for anastomotic leak we can basically use water soluble enemas. We can use water soluble enemas, or we can use CT scans. But these are obviously gonna take time and all. So CT scan and all, basically emergency CT scan and all. Okay. Now the clinical manifestations of this. Sorry, I forgot about the clinical manifestations of this. Okay, this can be basically there can be gas, there can be purulent or fecal discharge. Fecal discharge. Now, where is this discharge coming from? This is coming from the drain that we have put in place after the colorectal surgery or bowel surgery. Okay. Next one is it can be pelvic abscess presenting as a pelvic abscess, or it can be presenting as peritonitis. It can be presenting as peritonitis. Okay. Uh, okay. Now, treatment is basically uh, we basically go for percutaneous drainage. Okay. Treatment is percutaneous drainage. Now, this is basically done in patients who are hemodynamically. Okay, we have basically hemodynamically stable patients, stable non-septic patients, non-septic patients. Okay. Next is basically surgical repair. Next is surgical repair of the leak, anastomotic leak. That is basically we go for re-laparoscopy, re-laparoscopy and lavage and lavage. Okay. And next is basically next complication of this is basically post-operative bleeding. Post-operative bleeding. Okay, it is a very rare complication, but any surgery, it will basically result in post-operative bleeding. Okay. Basically, what happens is the patient presents with abnormal heart rate, and the patient presents with low blood pressure. Presents with low blood pressure. Okay, and basically how we confirm it is we basically measure hemoglobin and hematocrit and hematocrit. Okay. Next is the major one that the examiner wants you to know is ileus. We basically call it as post-operative ileus. Post-operative ileus. When you're talking about post-operative illness, ileus, this is basically any gastrointestinal surgery. Any gastrointestinal surgery, it can lead to post-operative ileus. Okay, and it is the pathophysiology of this is it is basically multifactorial. Multiple factors it can lead to development of paralytic ileus. Okay, and like. It is basically um, like we should basically use narcotics very carefully, and NSAIDs and placement of thoracic epidural with local anesthetic and all these can be used in the treatment of paralytic ileus. Okay, and like for the other one is we have to go for an nasogastric decompression. We have to go for nasogastric decompression, and we have to correction of electrolyte imbalances. These one are the major complications of surgery. Okay, basically when you're talking about post-operative complications of bowel resection and all, these ones are the main ones that you should always remember in this. Okay. Next question is basically esophageal. Sorry, we get this one. That is esophageal atresia. Okay, esophageal atresia. Now, basically, when we're talking about esophageal atresia, okay, this is basically which it can be congenital. Okay, which is congenital. Okay, now in this, basically, what happens is there is a blind proximal pouch, blind proximal pouch with a distal part. The distal part is that means the faraway part is present with tracheoesophageal fistula. Tracheoesophageal fistula. Okay. Tracheoesophageal fistula. Okay. Now, in this, basically, the first will do what are the clinical features of this. Okay. Initially, the affected infants. Okay, we said that it is congenital. So basically, affected infants, they have like they will basically present with drooling and and cyanotic episodes and cyanotic episodes on feeding, or basically whenever we attempt to feed the patient. Okay, and there can be polyhydramnios. Okay, polyhydramnios. Okay, this is occurring due to failure to swallow amniotic fluid. Failure to swallow amniotic fluid. Okay, and this is associated with a condition. Okay, that is known as tracheoesophageal fistula. Okay, we already mentioned it over here. Okay, it is associated with a condition that is known as tracheoesophageal fistula. Okay, we'll just add tracheoesophageal fistula in this for timing, because we'll discuss both of these conditions. Okay, now in this, okay, they are basically associated. tracheoesophageal fistula, okay, or like atresia plus like why is it occurring? First and foremost, will what are the causes of tracheoesophageal fistula? We can basically say it is again the same thing. It is congenital. Okay, this is basically occurring due to failed fusion. Sorry, failed fusion of tracheoesophageal ridges or tracheoesophageal ridges after fourth week of embryological development, or basically an embryonic development, fourth week of embryonic development. Okay, and this can also occur due to necrosis due to necrosis by tracheostomy by tracheostomy tube tracheostomy tube. Okay, and tracheostomy tube in apposition to ng tube. That is basically ng tube is nasogastric tube. Okay, now tracheoesophageal fistula. Okay, TOF or TEF. You can make a mnemonic as you want, or basically a short form. Okay, the associated anomalies. The associated anomalies. With this, we basically write it down as Vactor. Okay, VACTER and R. Okay, Vactor. Okay, first is vertebral defects. It is associated with what? It can be associated with vertebral defects. It can be associated with anorectal malformation. Anorectal malformation. Next is it can be associated with cardiac defect. When you're talking about cardiac defect, okay, it is basically associated with patent victus arteriosus or ventricular septal defect. Next is basically TEF. T is nothing but TEF, and it can present. R is radial hypoplasia and renal agenesis agenesis. So basically, if you are preparing for PG, for USMLE or anything, you have to remember what are the associated anomalies that you see with tracheoesophageal fistula. Okay, that is basically vertebral defects, anorectal malformation, cardiac defect, TEF, that is tracheoesophageal fistula, and radial hypoplasia and renal agenesis Okay, now in this we